We're going live now, and I'm waiting for Dr. Finley to join. Today we're going to talk about racial inequalities in health across one's entire lifespan and what we can do together to narrow the gap in Black and Brown communities. So while we're waiting for Dr. Nicola Finley to join, I just want to read you her bio. Dr. Finley is board certified in internal medicine, and she also completed the Integrative Medicine Fellowship at the University of Arizona. She's a graduate of George Washington University School of Medicine and also Brown University. She works at Canyon Ranch in Tucson, and she practices integrative medicine with an emphasis on prevention and wellness. Prior to that, Dr. Finley worked for over 10 years in Tucson's economically disadvantaged communities at El Rio Community Health Center and also at St. Mary's in Tucson. She's an adjunct faculty member at the Mel and Enid Zuckerman College of Public Health at the University of Arizona. And it's such a pleasure to have Dr. Finley together to talk about the research on these health inequalities, because it really is a multifactorial situation, and it's not only social inequities, but inequalities, but there's so many inequalities in health, and we're going to share with you what we can do together to help narrow this gap. So let's see what Dr. Finley's going to... Here we go. We're going live.
Karen,
good morning.
I'm so
yes,
sorry.
This is much better. I just read your bio, so let's get right into it.
Okay, perfect.
So in my personal opinion, I think it's our birthright to be entitled to good health. But I also want to start our conversation on a positive note and acknowledge all the goodness in this world, because there are many organizations that are taking action and thriving for this reform, for social justice and racial and health equality. And we are becoming much more aware of our biases. We're educating through the churches, synagogues, and in the schools. And we do have a lot more diversity, inclusion in the corporate world and around education. And this is a good thing, but there's still so much more we can do to narrow the gap in these inequalities, both socially and, regarding our healthcare. But today, let's just focus on healthcare. So for me, as like an integrative health coach, I'm really particularly interested in the research that you have to share and what you're experiencing in the medical community and also around this COVID-19 pandemic. And any of these viewers can please DM us directly if you want the research that we're going to be discussing today. So you can DM either myself or at Nicola Finley, MD, and we'll share the research with you.
Thanks, Karen. Thanks so much for having me on. And, I should start by saying this was Karen's idea for us to talk about this, because remember, Karen, we were going to talk about gut health. And I think at the time that we are in, it's really overdue for us to talk about racial inequalities. And this is a topic that I've lectured on many a times. I've been in practice as an African-American physician for 20 years, but I've never given this presentation in front of a diverse audience. So I think we're in the middle of change, and I think that's good. We want to improve the health and wellness for everyone. And, we're going to talk about evidence-based research, and there are striking inequalities in Brown and Black communities. And as physicians and as a healthcare system, it's not our intent to have these striking inequalities. But the reality is, this is where we are. And so what can we do together to overcome these inequalities? And there are also inequalities in other communities. There are inequalities in the LGBTQ community, people with disabilities, rural white communities. So it's a broader conversation for sure. So I thought I would start by talking about how this is a very complex topic. So I'd love to look at this from a very broad lens. And we think about it from a broad lens, we think about brown and black communities as being so diverse. If we look at African Americans, what influences someone's health is not just our race, it's also our age, our socioeconomic class, level of education, where we live. If we look at the Hispanic Latinx community, which country their ancestors are from, whether it's Mexicano, Puerto Rican, Cuban. So I think that diversity is so important. So thanks, Karen, for starting off the conversation. And I think COVID-19 is a great place for us to start. It's been in the media a lot, and we know that there are racial inequalities in terms of COVID-19, not just in terms of the number of cases, but also in terms of the inequalities in mortality or death. And the first article that I thought I would mention is an article from JAMA. And this article is from April of this year. And and it was called Failing Another National Stress Test on Health Disparities. And one of the co-authors was Dr. Richard Carmona, who is a former U.S. Surgeon General, who is an executive at Canyon Ranch. And really what they talked about was the social determinants of health and how it applies to COVID-19. And so when we decided for us to have this conversation, I thought it would be nice to talk about health disparities over one's lifespan and talk about those social determinants of health.
Love it.
Great. Okay. So if we think about those social determinants of health, we really could think about it from a model that looks at all different layers. We call it in medicine, it's multifactorial. So social determinants of health could include poverty, incarceration, racial discrimination, violence, environmental exposures, lack of access to care. And we could think of it in different layers. We could think of it from the patient factors in terms of lifestyle that we choose, or risk factors, if we exercise, if we're not physically active, if we smoke or drink or do drugs. We could think of our ethnicity, our gender. We could think of our socioeconomic class. Genetics play a role, but that's clearly not the whole picture. And then we could think of it from the community and neighborhood level. We could think of housing and how that impacts our health, our social networks. And we can't forget the provider level. We can think about cultural competency that providers may or may not have, implicit bias, how providers communicate with their patients, and then of course the systemic factors, racial, structural racism, how we could think about lack of access to quality of care. And again, as physicians, we take a Hippocratic oath. We want to take care of all ethnicities, but these racial disparities exist.
Wow. And there are so many factors that are going into play. You know, this is not just racism. This is not just social inequalities. You have to really look at this as a holistic piece. And there's so much education that needs to be done from the physician level down to the patient empowerment and the patient owning their own health. And, you know, I guess this is what integrative medicine is all about. You know, I'm an integrative health coach. You're an integrative physician. It's a patient-centered approach that covers all of those factors, and we have to take all of those factors into consideration. You know, for really supporting and healing our patients. This is great. We're gonna have so much information here, and we'll summarize this. I'll summarize this. I'll tape the interview and we'll put it in both of our feed posts so that people can go back and watch it and take some notes, because I know we're going to be covering a lot today, and we'll try to do it in less than 30 minutes. So can we just talk about maternal health, or start with maternal health? My son just got married in October. My daughter-in-law wants to get pregnant. You know, African Americans die at a rate of 3 to 4 times that of whites from pregnancy-related complications. And you know, they're not always referred to a high-risk OB when needed. So can you touch on maternal health and maybe why we're having some of these inequalities?
Definitely. So the research that I want to share is from the CDC, and it is the Morbidity and Mortality Weekly Report that came out in September 6, 2019. Dr. Pearson was the lead physician on that
Mm-hmm.
article. So yes, why I think it's so important to talk about maternal health. I mean, I think about it in my own family, how there were inequalities in terms of specifically my cousin when she was pregnant. And what's interesting about maternity health is it's not specifically related to socioeconomic class. So this is a statistic from that article from September of last year. The pregnancy-related mortality rates among Black women who have completed college education or higher was 1.6 times that of white women with less than a high school diploma. So I think so often when we think of inequalities, we think of inequalities in terms of racial inequalities overlapping with socioeconomic inequalities. This is an example where that's not always the case. And I also want to bring in the data in terms of Native Americans, because again, there's a disproportionate number of deaths, not just among Black Americans, but among Native Americans as well. And we know these are preventable. What we're talking about is preventable. And in terms of that data, for Black Americans and Native American women greater than 30 years of age, approximately their mortality rate, pregnancy-related mortality rate, was approximately 4 to 5 times that of their white counterparts. So that begs the question, why is that? I mean, again,
Mm-hmm.
these are striking numbers. So it's a difference in access of care. It's the quality of care. So it's not just access of care. It's the prevalence of chronic diseases in terms of hypertension, diabetes, and like you said, Karen, being referred to specialists. And that's important. And making sure we have care as women throughout our pregnancy, before we get pregnant, as
Mm-hmm.
during pregnancy, and after pregnancy. Because after pregnancy, we need to refer patients to specialists and continue that conversation.
Mm-hmm. Yeah. So you're a mom, I'm a mom. Let's talk about children's health care and asthma. African American children face a 4.9-fold higher asthma mortality rate. Hispanic children are 1.5 times more likely to die due to asthma related complications. Why is this so?
Yeah, I'm a mom. My daughter's 13, and I was just talking to a family friend, and her son has asthma. What we know is that this disparity, probably a good percent of it, is related to financial hardship and social hardship. And we know poor housing quality plays a role. And it's not just that. But if we think of poor housing quality, we can think of allergens related to mold in someone's house,
Mm-hmm.
related to if their faucets leak and there is moisture in someone's house, we can see mold, we can see dust mites, rodents, cockroaches. So there's definitely a variety, but there's more to that. There's studies show that my children of African American and Latino descent are less likely to be prescribed a controller medication when indicated. And what we know is that there's poor health literacy. And this data that I'm sharing is from the American Academy of Pediatrics, their pediatrics journal from March 2017, entitled Solutions for Asthma Disparities. So I think this is an example of how it's multifactorial, but socioeconomic class plays a role as well, because African American children are 4 times more likely to be admitted to the hospital for asthma as compared to white children.
Yeah, I think environmental health is a huge topic, and it's an area where most of us really are not that aware. I personally just had my home tested for mold, and
Oh.
being on the board of the environmental working group, I'm very passionate about environmental health. And so you're right, education and just we have so much to share, and we have so much to really learn about the environment and its impact. Heart disease. Heart disease is the leading cause of death for all Americans. What are some of the health disparities in heart disease among people of color?
Yes, and so the peer-reviewed journal article that I want to share for this one is from the Cleveland Clinic Journal of Medicine from September 2019, entitled Disparities in Cardiovascular Care, Past, Present, and Solutions. The lead physician is out of Northwestern University. We know African Americans specifically are less likely to be referred for angioplasty when they have a heart attack, less likely to be referred for heart transplant if an African American if we have heart failure, and we know that they're less likely to receive implantable defibrillators, and so it's important that we think about this. Again, it's lack of access to care, but it's also receiving lower quality of care. And we also know something in terms of our Hispanic and Latinx population is something called the Hispanic health paradox. If we think about Hispanics and we think about the diversity, the rich diversity in terms of our Latino patients, whether it's Puerto Rican, Cuban, from Venezuela, we know that there's diversity. But heart disease is the #1 killer for the Hispanic population. But despite having increased risk factors, diabetes, heart disease, social determinants of health in terms of maybe as overall lack of access to care, overall a language barrier, we find that mortality rate or death rates are lower in Hispanics compared to white populations. So that's really interesting.
That's really interesting.
Yeah.
So
and
it's
so
the family support. It's the family support.
You got it. I work here in Tucson, and we're an hour away from the Mexican border. And I remember at my last job when I was at St. Mary's Hospital, there was a patient who was clearly the matriarch of her family, and she was Nana for sure.
Aww.
And she was in the ICU, and I needed to have a family meeting, and we couldn't have the family meeting in any room in the hospital because her family was so large. We had to go outside. So that's that social support that can buffer that disparity.
Oh, we have a Nana in our family, and she's our matriarch too.
Oh.
Just want to tell everybody that we're here with Dr. Nicola Finley, board certified in internal medicine for those who join late. We're talking about health disparities across a lifespan in Black and Brown communities and communities of color. Let's touch on issues around cancer disparities, delays in diagnoses, patients being treated at a later stage in cancer, which makes it more difficult to cure, which is then going to give us higher mortality rates.
Thanks, Karen. Yes, and so we know there are higher cancer mortality rates and shorter survival time among African Americans as well as Native Americans. And when we think about that, I thought I would just share a few statistics. And this data that I'm talking about, I'm pulling from the American Cancer Society. And we know the African American women have higher breast cancer rates, death rates, and everything you just said in terms of being more advanced at the stage of diagnosis, and there are more comorbidities in terms of diabetes, being overweight, but also the biology is important. The type of breast cancer African American women overall develop are more aggressive. And so we could also look at the treatment that African American women are offered. And for African American men are 2.4 times more likely than white men to die as a result of prostate cancer. So this really leads to us talking about implicit bias. And we've been sharing themes of these social determinants of health. We've been sharing themes of inequalities of health. And again, I know there are physicians listening to this, and I want to do right by my profession. I don't believe it's the intent of the healthcare system to perpetuate these inequalities, but they exist. And so if we think about implicit racial bias, we can think about how it's not our intent to have this bias, but it exists. And it impacts the patient-provider relationship. It impacts as doctors. what treatments we offer our patients. It impacts the outcome of our patients. And so it's really the thoughts and attitudes that we as providers have, or feelings that we have, that exist outside of our conscious awareness. And we know that these behaviors or attitudes that we have, what the research shows, can result in patients of color being kept waiting longer for an assessment, providers spending more time with white patients, providers collaborating more with patients who are Caucasian. And that begs the question of us talking about the shared decision making. It's so important to have that relationship, that doctor-patient relationship. And so, Karen, you've heard me say this. I think as patients, we should talk to our doctors like we talk to our hairstylists, like we talk to our barbers. Our defenses are down. We are having a conversation. We meet often with our hairstylists and barbers, and we need, as patients, to have those preventative appointments with our doctors on a regular basis.
Yeah, it's really, we're not aware of these implicit biases. These are unintentional biases. And to educate our patients and to have this partnership, which is integrative medicine, right? It's the partnership with the patient and the practitioner to get to know your physician. Although it's another topic of discussion is the amount of time a physician can spend with the patient to really get to know that patient, but getting to know then the doctor's team and the staff of your physician, and really look at it as a team approach where the patient is the center of his or her own health, and advocating for yourself, patient empowerment. And I like your suggestion about talking to your doctor like he or she is your hairstylist. Let's develop this relationship. Let's get to know each other so we feel comfortable.
Yeah, I agree, Karen. And when we think about that, then that is so important. And it's and I should say that work is being done in this regard in terms of cultural competency training for providers. Healthcare systems are working on this. We are working on increasing workforce diversity. So if we think about workforce diversity, we could think about the percent of physicians of color. And I got this data from the Association of the American Medical Colleges of the percent of active physicians by race and ethnicity. And this is from 2018. 56% identified as white, 17% identified as Asian, 5.8% identified as Hispanic, and 5% identified as Black or African American, and the race was unknown in 13%. So I think having that diversity in terms of our providers, as well as diversity in terms of research participants.
That's great. That's great advice. And for any of our viewers who want the research, feel free to DM either of us directly, and we'll send you these articles. So this is great, Dr. Finley. Thank you so much.
I know we were going to talk about end-of-life care.
End-of-life care. And what are you observing for these inequalities around late-stage lives?
Yeah, this is a topic I think that doesn't come up that often. So I think it's so nice that we're talking about this over the lifespan. And when we think about end-of-life care, we're thinking about advanced care planning. We're thinking about having a power of attorney, advance directive. So basically making decisions ahead of time so you know what healthcare you want when you're facing a medical crisis. And the National Institute on Aging from the NIH is a great resource for more information. But I'll be citing a study from the American Journal of Hospital Palliative Care, and this is from July 2017. The lead physician is Dr. Rhodes out of UT Southwestern Medical Center. And what we know is that their health, again, the theme we're talking about, their health racial disparities and prognosis, or communicating about the outcome of one's condition, was less than half as likely to occur with conversations in Black and Latino patients. And what we know is there might be a lack of knowledge among African American, Latino, Native American patients, and there might be fear among our patients of color that if they enter hospice or if they explore palliative medicine, that they might quicken the time to death, or that the providers might not give them adequate care, or maybe their perception is that it conflicts with their faith and religious beliefs. And so I think what this article talks about is, if we have culturally sensitive videos to talk to patients about, handouts to talk to patients about, non-medical health lay people talking about this, and people that they trust from their community, maybe from faith-based organizations, this might be a better option for patients of color to think about these options for end-of-life care.
Oh, I love that idea, providing videos and handouts from your practitioners and through education, because I could see how there could be a lot of distrust in the healthcare system, you know, for all of us, but especially with patients of color.
Yes, definitely. And, you know, that goes back to the structural racism. And and it is intentional that we're having this conversation on Juneteenth. And I think this is important for us to talk about our history. We as providers, we need to openly have this dialogue with our patients. And I hope patients of color openly have this dialogue with their physicians. And so many of the viewers might be familiar with the Tuskegee study. And if they want to obtain more details, if you Google CDC Tuskegee, it'll come up. And this is just an unfortunate example of racism in healthcare, with the Tuskegee syphilis experiment that started in the 1930s, ended in the 1970s. They wanted the government, the US government, wanted to look at how the natural history of syphilis, and they chose to truly experiment on low-income African-American men in Alabama. And who had syphilis, and there was deceit, and then they monitored them over time and continue to monitor them even after the development of syphilis, which is a treatment for development of penicillin, which is a treatment for syphilis, and didn't acknowledge and didn't share that information with these men until the 1970s. So I think and if someone wants more information, they could look at the website, and there was a movie about it, Miss Evers' Boys. And I remember that movie came out in the it came out in the late 1990s, and I was in medical school at the time. And so I think that's important that we know our history.
Wow, that's kind of disturbing.
It's very disturbing. Yeah, it is. It is.
Yeah. I'm a supporter of an organization. It's called I Am for Us. It's integrative medicine for the underserved, and it's a fabulous organization. I'm their nutrition sponsor, and their mission is to support integrative medicine and promote health in the underserved populations. And they're working towards health equity, patient empowerment, just like we're talking about, patient self-care, and then prevention. So can you talk a bit about some of the inequalities around the underserved? I know you've got a lot of experience and 13 years at El Rio, and how this affects their opportunities for good health care.
Definitely. And the first thing I think about when I think about the underserved is lack of access to care. And that's huge. And that is a significant barrier, truly, to us having equality when it comes to healthcare, because we want health equity. Language barriers is definitely another barrier that we need to think about, especially, again, being here in Tucson, Arizona. But health literacy is something that I thought we can concentrate on a little bit. If we think about health literacy, we want to make sure as physicians, we are talking to our patients in a way that they understand, and that patients feel comfortable responding back to us, letting us know what they understood. And so we can make some changes, because if we can work with health literacy, that might lead to increased appointments, because patients then will understand the importance of the preventative appointments. We can also have health literacy in terms of that shared decision making that I talked about, which is so important. And when we think about health literacy, I love the idea of patients doing research on whatever condition they think they have, or they do have, or whatever symptoms they have, talking to their doctor or their healthcare provider about that, and then doing research afterwards. Maybe it's getting a second opinion, or it's maybe having this concept of a wellness village. So this
I
concept of a
love that.
it's a concept of a wellness village is the idea that yes, we have a wellness team. Like you as a life coach, you're part of the wellness team. Me as a physician, I'm part of the wellness team. But your wellness village would be your family members, your friends, your neighbors, and maybe someone can come with you to the doctor's appointment, because having a second set of ears is always important. When a patient is sick, it is hard for him or her to really absorb all the information as doctors that we're telling someone. It's hard to, maybe they might not want to hear it, but having that second person with you, that wellness village to bounce ideas off of, is so important.
Oh, that's huge. Surrounding yourself with the support. And I remember when my mom had cancer and my dad had Alzheimer's disease, I went to all the appointments with them because as a patient, sometimes you can't take that in. It's just overwhelming. And so you have that patient advocate, and wow, we're really lucky to have that support. And so I think it's important to encourage that.
And yeah, and
Yeah.
that's actually so important, because I think about that when I remember working at El Rio, and the patients in the waiting room, they would talk to each other
Yeah.
and they could create a little wellness
Yeah.
village. And at Canyon Ranch, I noticed that as well with all the providers that we have. It's a team approach, but when the clients of Canyon Ranch come, they talk to each other and they develop a wellness village at the resort as well as back at home, of course.
Yeah. Well, Canyon Ranch, was really my inspiration 30 years ago to get into integrative
Oh,
health. Yeah, I mean, they've been practicing a proactive integrative approach for, I think they've been around for 40 years, founded by Mel
you're
Zuckerman. So, I mean, Canyon Ranch, that's my bliss. That's really integrative medicine at its best.
I agree. It's my
Yeah.
bliss too. Our founders, Mel and Enid Zuckerman, and our new owners, Cami and John Goff, just wonderful in terms of the mission, and wellness is at our core. And so I
Hmm.
think it is so important to think about wellness. Again, just like you said, an integrative approach is really looking at the whole person, mind, body, spirit. And if we think about spirituality, it's really our outlook in life. It's our sense of purpose, and it's looking at our lifestyle approaches.
Yeah, absolutely. I've
Hmm.
been to your lectures at Canyon Ranch,
Oh,
and
thanks.
I really love your walk and talks. You do these diabetes walk and talks, gut health walk and talks. You have so many different topics that you talk about how we can upgrade our lifestyle and things that we can think about to help improve our own health. So I'm very grateful for your work at Canyon Ranch.
Oh, thanks so much. I appreciate it. And,
Yeah.
one quote that I often talk about is from William Osler, and it says that it's much more important to know what sort of patient has a disease than what sort of disease a patient has. And I think that's something we could think about when we think about inequalities, racial inequalities in health.
Right. We're all bio-individual. We cannot treat every person the same.
It's personalized
Yeah.
medicine.
Yep.
And so it's really getting to know each person and not making assumptions about a person based on their race, because like we talked about, there's so many factors that
Hmm.
play into that influences someone's health. And we really should celebrate our
Hmm.
diversity, because we're a diverse community. And
I
it's
love it.
so important to celebrate that diversity. But with all of the racial protesting that's going on now, Black Lives Matter, I think it's so important that we think about how we see racial inequalities, or what we can do about racial inequalities in so many industries. My industry is healthcare,
Hmm.
but there's education, there's housing, there's police brutality. So we're really in a time of change. And so I'm excited that we have such a diverse audience and a wider view looking at this topic.
Hmm.
Yeah,
Wonderful.
yeah. So, if I were to add a few things in terms of a conclusion, in terms of thoughts, in terms of what we can do next, we've touched on so many of them in terms of, as doctors, we need to take a look at cultural competency. There's another term called cultural humility in terms of looking at our own biases and how we can change, thinking about the competency and our attitudes towards our patients. Structurally, we need to think about this from a systemic racism point of view. Working with communities, working with faith-based communities, getting that wellness village we talked about. And I want, as people of color, we want to take our own responsibility. We want to control what we can control, so we could control our lifestyle. We could exercise. We could eat healthy foods, which is your passion. We can talk about our unhealthy behaviors, maybe smoking, alcohol, and what we can do. And I love this idea of thinking about wellness, passing it along to different generations. I'm a mom, and so I, as you might know, Karen, I love to dance. So my daughter has her friends over. I'm doing a little Zumba video, and her friends just walk by, so it's fine. And she sees me exercising. My husband, he's a triathlete, which you know, and he's doing his thing, and we exercise as a family riding bicycles. But I want my daughter to know this is part of our lifestyle. And if I can model that for her, then she'll model that for her family, and it'll continue passed along in generations.
Love it. You're a great role model for your daughter, really.
Oh, thanks.
Fantastic.
Thanks.
I read the article in the Tucson News about your family. It was very special.
Thanks,
the
Karen.
Dad of the Year, Tony.
Oh, yeah, that's Tony. He's pretty awesome. And, it's just so nice that we can think about racial disparities. And really, Karen, the fact that you wanted to talk about this, you're a healthcare coach, you're in Chicago, you see a variety of patients. And I'm just so thrilled that this was a topic that you decided for us to talk about. So thank you.
Oh, of course. This is really interesting to me. And, we're both graduates of the University of Arizona Center for Integrative Medicine, and they recently launched a new app. It's called My Wellness Coach, and they tested it in the underserved communities, and it's written at a 5th grade level because we talked about languaging and how we can talk to clients and patients so that they can understand. And so I really love this app. It's free right now for anybody who wants to download it, and it's your own personal health coach. And I actually helped author the environmental health section, but it covers all 7 core areas of health, and that's your nutrition, your exercise, your movements, our relationships, our spirituality, that interconnection to self, resiliency, environment, and sleep. And it asks you to set goals, and then it coaches you along the way. So I encourage our viewers to download the app. It's called My Wellness Coach.
Oh, that sounds great. I don't think I have
it's a really
that
good
app.
Yeah.
I'm going to download it.
Great.
And, I thank you for mentioning the Arizona Integrative Medicine Fellowship, because that's a fellowship that I did as a 2-year fellowship, because what Karen was just talking about, I didn't get in medical school. And so I had to seek it out in a fellowship afterwards through the University of Arizona, Dr. Andrew Wild's program. And I learned evidence-based approaches to integrative medicine. And that's what I practice now. I practice integrative medicine at Canyon Ranch.
Love it. Yeah. And you're amazing at it.
Oh, thanks, Karen.
So is there anything else you want to share? And then we can just kind of summarize the bullet points.
No, I just want to carry the conversation that we can have an open dialogue with patients and their providers, and really with each other. And so I think this starts the conversation, and we're not the only ones having this dialogue. So I think it's in the forefront, which I think is great.
Great. So we want an open dialogue. We want to focus on prevention and early detection. We want our physicians to take responsibility of these racial biases, and the patient needs to be aware of these biases as well. So it's not, the onus is not just on the practitioner, it's on the patients as well. And this is a patient-centered care approach, which is what integrative medicine is about, and really good medicine. We need to make this a generational priority and pass on wellness to our children and our grandchildren. And really, it's important that we role model for our kids, taking care of ourselves, self-care. talking with your physician, to your doctor, to your healthcare provider, to your clinician, the way you would talk to your hairstylist. I love that tip. And to really get to know them and allow them to get to know you, and getting to know your doctor's staff. And we do need to focus in on what's in our control. And there's so much that is in our control. There's plenty that's not, and we're going to work on that through education. And but really, there's a lot we can do that is in our control. And then thinking about those 7 core areas of health: our nutrition, our exercise, our spirituality, our resilience, your sleep, and your relationships, and the whole family support.
I agree. And I would add on acknowledging that structural racism exists and what can we do about that. And that was something I would add on as well.
This is great.
I love the way you summarized it. Perfect.
This is wonderful. So we'll be recording, we recorded this interview, and we'll both save it in our feeds. And please reach out to us if you want any research. DM us directly. And I'm just super grateful for Dr. Nicola Finley, board certified internal medicine. Thank you.
Thank
Nicola.
you, Karen, for organizing this. I enjoyed working with you. So I should just mention Karen and I collaborated back and forth on this, and I am so thankful that I had an opportunity to share this information. Thank you.
Thank you. Bye.
Take care.
Okay.
Bye-bye.
Bye-bye.